Hello, I am Dr. Manas Kalra. I am a pediatric hematologist and oncologist at Indraprastha Apollo Hospital, Delhi. Today I'll be talking about a very important disease that I treat in my day in and day out practice, which is blood cancer in children. There are two common forms: acute lymphoblastic leukemia, commonly known as ALL, and acute myeloid leukemia, commonly known as AML. And I'll be highlighting these two blood cancers and mainly the pediatric aspects of these two cancers. So just to briefly introduce the topic, for some it might be a little surprising, but actually more than 2 lakh children are diagnosed with cancer every year, and 80% of these children are actually living in the developing world. In India, around 45 to 50,000 children with cancers are diagnosed every year, and acute leukemias, which is blood cancer, is the most common form of cancer known to the pediatric age group, and it constitutes somewhere around 30% of all childhood malignancies. ALL, as I said, acute lymphoblastic leukemia, is 5 times more common than the other common form of acute leukemia, that is AML. And this graph beautifully depicts what the Pediatric Oncology Society, our community as a whole, has achieved in the last few decades. The outcome of ALL has markedly improved in the last few decades to a figure of, say, 80 to 85%, and it indeed is very gratifying for most of the pediatric oncologists, for the families, for the patients who are suffering from once known to be a uniformly fatal and deadly disease, and we are now able to cure somewhere around 85% of children with ALL in this day and age. And what has led to this improvement in outcome? So the first thing is the better supportive care. We are able to manage children with the help of our colleagues, the nurses, the social worker, the psychologist, and all those other aspects which are very important and which were actually neglected in the past few decades. There is easy availability of safe blood products. There is early diagnosis, and children are referred to a pediatric oncology center very well in time, and that helps us to treat them at the right time and get a good outcome of their leukemia. There is increased awareness, there is improved literacy, there is risk-based stratification and therapy modification. So if a child has a standard risk ALL, we do not give very aggressive chemotherapy because they probably are just cured just with simple chemotherapeutic agents. And if a child has a high-risk form of an ALL, then that child requires really aggressive chemotherapy to control his cancer. And obviously the basis of all this has been collaborative clinical trials, which have been conducted in a huge fashion, mainly in the Western world, but also now it's coming up in a big way in the developing world. And with these clinical trials, we are able to cure, understand the biology of the leukemia, the treatment policies, and we are able to improve the outcome of leukemia to an extent of, say, 80 to 85%. What causes acute leukemia? This is the first question that most of the parents ask when their child is diagnosed with cancer. Why did this happen to my child? Whether I did something wrong, or whether I was supposed to do something and I did not do it, or I did something that I wasn't supposed to do. So there's no real answer for that. The cause of blood cancer in children is largely unknown. There are a few postulates: some kind of chemicals, pesticides, ionizing radiation, cancer predisposing syndromes. All these lead to a high incidence of acute leukemia in children. A common form of a syndrome which is called Down syndrome. These children have almost 20 times higher risk of developing leukemia as compared to the normal population. But if we look at all these factors, say, look at ionizing radiation causing cancers in patients, in children who were exposed to that, say, in near Hiroshima, Nagasaki, where, the nuclear bomb attacks had happened, we are only able to find these causes in a very small percentage of children who suffer from acute leukemia. So largely, I would say that the cause of acute leukemia is unknown. The next thing is, what are the symptoms of acute leukemia? So the most common symptom with which the children present to us or to their pediatricians is fever. So fever goes on, and the common causes of fever, say typhoid fever, tuberculosis, viral infections, bacterial infections, all these have been ruled out, but the fever still persists, and that is the time when we should think that is there something wrong in the blood system of the patient, that is blood formation is inappropriate due to some reasons and this fever is going on. Sometimes children present with bruises and petechiae. These are bluish spots that happen because of low platelet count. Bleeding from any other orifice, say bleeding from their stools or urine, can also be some form of presentations in acute leukemia. Bony pains is a very important manifestation of acute leukemia because the leukemia starts within the bone marrow. So when the leukemic cells, that is the cancer cells, fill the bone marrow, a child starts complaining of bony pain. So if a child complains of, say, knee pain, back pain, we need to take this very seriously, because normally children are the ones who do not complain of pain and are happy with their lives and are always playing. But if you notice a child who's developed a joint swelling or pain in a particular joint or say in the back, then please you need this child to be evaluated properly to rule out leukemia. Progressive paleness of the body, because the hemoglobin starts dropping due to the poor production of blood from the bone marrow and replacement by cancer cells that are commonly called as blasts, the hemoglobin drops and the child starts looking progressively pale. Sometimes parents also take their children to doctors because they have noticed swellings in their neck or in groin or under the armpits, and these are basically lymph node swellings which can become noticeable if they are reasonably big in size. The other presentations can be because of involvement of leukemia, involvement of brain secondary to leukemia, and children with the brain involvement can present with headache, rarely with seizures. Sometimes they can have a facial palsy, that is the nerve supply to the face gets affected because of the leukemic infiltration, and they present with deviation of the mouth. Sometimes they present with abdominal distension because of organomegaly, that is liver enlargement, spleen enlargement, which causes the huge distension of abdomen, and children can present with that. 1% of the boys who have leukemia also present with testicular mass. So if you see that a child has a testicular swelling and it is painless, we always need to rule out leukemia or some kind of a cancer in those children. There are forms of leukemias which present with a chest mass, that is a mediastinal mass, and such children can have breathing difficulty, and they can also have facial puffiness secondary to the obstruction of the venous return, and that can be also seen mainly in T cell form of leukemia, and I'll show you examples of that. So if once the doctor examines the patient with a leukemia, what are the signs that he usually identifies in such a patient is pallor, petechiae or ecchymosis. He can also have small purpura, lymphadenopathy, hepatosplenomegaly, testicular swelling, and cranial nerve palsy or features of raised intracranial tension. And mind you, all these symptoms and signs are not present in every case. Every patient presents with a varied combination of signs and symptoms, and we just need to be very careful when we take the history and examine such patients. The other signs can be swelling of gums, chloromas or proptosis, and bony tenderness, and I'll show you some examples of this. So this is a child who presented to me with bleeding spots or bruises and ecchymosis, and you can clearly see that he's got all these bluish spots in his legs, and his platelet count was very low, and that was the reason why he had all these spots. Now these are few children with, you can see that on examination they have organomegaly, or the other boy has got lymphadenopathy, that is nodes in their neck region, which is quite obvious. Now this patient presented with a facial puffiness. He had breathing difficulty, was not able to lie down flat, and his X-ray clearly shows that there is a mediastinal widening, there is a pleural effusion. His white cell count was very, very high at the time of diagnosis, and we could establish a diagnosis and start treatment immediately, and that brought in a good respite in all his symptoms with immediate treatment. Now these are a few children who have presented with cranial nerve palsy. You can see eye deviation, face deviation because of the leukemic infiltration in the brain. Now these are patients with gum swelling, and this is quite characteristic in acute myeloid leukemia, and this is one of the features that we need to prompt a physician or a pediatrician or a oncologist to think that the disease might be acute myeloid leukemia. This boy, you can see in this photograph, has got a unilateral testicular swelling which was painless. He also had organomegaly pallor, and the diagnosis was leukemia with involvement of testis. This is quite an extreme presentation of leukemia. This is called chloroma. This girl presented with a very significant swelling in the eyes, which was basically leukemia deposit, and her primary diagnosis was acute myeloid leukemia. This patient also, you can see that one eye is protruding, and just see the beautiful response to the treatment, and you can see her eyes look absolutely normal, say within 1.5 months of therapy, and actually the eye swelling disappeared within first week of treatment. So very good result of treatment of acute myeloid leukemia. Now we all need to know, and as pediatricians or physicians, that leukemia is a great mimic. So very, very high index of suspicion is required whenever you have a patient where you're not able to exactly figure out what is going wrong. So a lot of times we see patients who have leukemia but have been treated for say few weeks with a possibility of enteric fever, tuberculosis, infectious mononucleosis. Some of the children are treated like nutritional anemias because they had anemia. Some are being treated for ITP because they had platelet count which was dropped, and they thought that probably it is an immune thrombocytopenia leading to this low platelet count. Some patients are thought to be having aplastic anemia and connective tissue disorders like JRA. So this is basically a rheumatological condition where children have joint swellings and joint pains, and they are just on treatment for rheumatoid arthritis, and actually what they have is underlying diagnosis is leukemia. Some of them are diagnosed with meningitis or some form of an undiagnosed neurological illness, but actually they have leukemic infiltration in the brain. So whenever a patient is assessed by a pediatrician, physician, neurologist, rheumatologist, we need to have a high index of suspicion. If the things are not going wrong, say in 1 week or 2 weeks of therapy, we need to make sure that we are not missing an underlying diagnosis of cancer. Some of the important things that I want to highlight at this stage is, please avoid administration of steroids in children with undiagnosed illness. So if you have a patient with say ITP and has got a mild anemia or a little bit rise of white cell count, we do not really want to give steroids to this patient unless and until we have made sure that we have done a bone marrow and the bone marrow does not show involvement of leukemic blasts. So very, very important, do not give steroids to children with undiagnosed illness. Make sure you have ruled out an underlying leukemia in any patient with JRA or joint pains or suspected to have a connective tissue disorder or ITP or aplastic anemia before we embark on such a kind of a therapy. Also very important is that avoid giving blood transfusion to a child with a undiagnosed anemia. We want, unless the child is extremely symptomatic because of anemia, is in CCF and is about to die, in such situations, yes, definitely we want to give blood transfusion, but try to avoid blood transfusion unless and until you have made a confirmed diagnosis of an underlying illness. And if the patient is not very symptomatic with anemia, 1 or 2 days of wait is not really going to alter the outcome. But in case you administer steroids to patients who have leukemia, we might just miss the boat and we might not be able to diagnose leukemia correctly, because some of the forms of leukemia, especially ALL, is very, very sensitive to steroids. So even one shot of say hydrocortisone injection just prior to giving a blood transfusion can actually control the leukemia or bring down the leukemic burden to such a good extent that for next few weeks to months we may not even be able to say that the patient has any problem. The child might just feel so good, and the child will be taken home by the parents and will think, okay, the child is doing very well, there's no problem. But actually later, eventually 100% this this child is going to present in a much severe form of leukemia at a later point of time. So that is very, very important, and we must need to imbibe this practice in our day-to-day medicine that we are doing. So how do we suspect that a patient has leukemia on the basis of CBC? Is the patient may have anemia, the patient may have leukemia, leukopenia or leukocytosis. Neutropenia is a very important thing, and lymphocytosis. So whenever you look at a CBC, always look at the absolute neutrophil count, absolute lymphocyte count, and if the patient is having a relative increase in lymphocyte count and the patient is progressing to develop more and more neutropenia, we need to evaluate for a serious underlying disorder by doing a bone marrow test and make sure that we have ruled out a leukemia in such a patient. And thrombocytopenia along with anemia, leukopenia or leukocytosis again points that there is something wrong with the bone marrow. So usually the dictum is that when we have two cell line involvement in a patient, something is wrong in the marrow and we better check that. And even if we have one cell line involvement but we have a history of some kind of an undiagnosed illness or a persistent fever or some organomegaly, it's better that we do a marrow and rule out an underlying malignant infiltration. So if we look at the CBC, here the patient has a hemoglobin of 8, a white cell count of 5,000 and a platelet count of 1.4. You might just say, okay, borderline thrombocytopenia, okay, white cell count, so just mild anemia, maybe it's a nutritional anemia, let's give a trial of iron or B12 or whatever. But when you look at the DLC in this patient, his neutrophil percentage is only 10%. So such a patient actually has severe neutropenia. So if you look at neutropenia, anemia, and also there is mild thrombocytopenia, this patient definitely needs some kind of a bone marrow evaluation to rule out an underlying illness. And always ask for a peripheral smear, a good pathologist who looks at the peripheral smear and looks at the white cell morphology, looks at the platelet count, looks at the hemoglobin, our red cell morphology. We can to a great extent pick leukemias in our patients and facilitate early diagnosis, and that definitely reflects into a good outcome eventually. Look for blasts. If there are blasts present in the peripheral smear, that's quite obvious that the patient has leukemia. A lot of times it is reported as, say, blastoid cells or some abnormal cells or atypical lymphocytes. It's always better that we get this peripheral smear reviewed by an experienced hematologist and do a bone marrow aspirate and to rule out a leukemia. The other markers for increased cell turnover can be an increased LDH or a high uric acid, but usually the disease is a little advanced at this stage, and we want to pick leukemia at early stages because that definitely makes the outcome of leukemia better. Some children present with very advanced stages, like the boy I showed you with the chest mass and pleural effusion and a very high white cell count. Such patients have a very high uric acid. They are already having kidney damage. Their potassium may be high, their calcium may be low, their phosphorus may be high. So we need to identify patients at the right time, and even if they are presenting with a tumor lysis syndrome, a good amount of hydration before we actually start the treatment for leukemia, and giving allopurinol to bring down the uric acid level actually improves the tumor lysis in most of our patients. A chest X-ray is usually recommended at the time of diagnosis to rule out a mediastinal mass. But the main diagnosis of leukemia is by doing a bone marrow aspirate, and it shows at least a presence of 20% of blast cells, and that actually confirms the diagnosis of leukemia. Sometimes the blast percentage might be a little low, but if we are able to identify a particular chromosomal translocation or a genetic abnormality which is very characteristic of, say, AML, then we diagnose acute myeloid leukemia even if there are less percentage of blasts. when we look at the blasts, there are basically two types of blasts for whenever we talk about acute leukemias. Either they are lymphoblasts or myeloblasts. Now you can see in this picture, you can easily make out the difference between a myeloblast and a lymphoblast. The lymphoblasts are relatively smaller in size. They have a coarse chromatin. The nucleoli are usually absent to indistinct, and they do not have much of a cytoplasm. They lack our rods, and there is less of a background dysplasia. Whereas a myeloblast is actually characterized by large blasts with a finely dispersed chromatin, often prominent nucleoli, abundant cytoplasm, and our rods may be present in M2, M3 variants of AML along with the background dysplasia. So it's quite clearly written how to differentiate, but in the actual practice it might be tricky at times to differentiate between a lymphoblast and a myeloblast, and at that point of time it's usually the flow cytometry that helps us to diagnose what form of blast they are. So I won't go into details of the type of blast morphology, but L1, L2 and L3 are the three types of ALL blast, acute lymphoblastic leukemia blast, and these are the three types of ALL with the initial and the FAB classification. That is a conventional way of classifying ALL. Now L3 blasts, I would just take a second to just describe these blasts. Now these are actually seen in a form of leukemia which is also called Burkitt's leukemia, which is also known as L3 form of ALL. Now these blasts have got these cytoplasmic vacuolation and intensely basophilic cytoplasm, which is very characteristic, and it is present with the stage 4 involvement of this particular form of lymphoma, which is Burkitt's lymphoma. Once the marrow is involved, we call it a Burkitt leukemia, and they've got this characteristic kind of a blast, and the treatment strategy of Burkitt's leukemia is very, very different from the L1 and L2 ALLs, so I won't go into details of how we manage L3 form of leukemia. So this tabular column actually beautifully differentiates ALL and AML based on the morphology, cytochemistry and biochemical parameters. So I've already described the differences between ALL and AML blasts, but then important thing is the presence of myeloperoxidase stain or Sudan black B actually characterizes AML, and PAS positivity may be present in ALL forms of blasts, and TDT is usually positive in L1 and L2 forms of ALL and negative in L3 form of leukemia. But the most important test which actually tells whether we are dealing with ALL or AML is what is called as a flow cytometry, and based on the flow cytometry we further classify ALL into a B precursor ALL, mature B ALL, T cell ALL, and these are the markers for AML, and AML is also further classified into different variants, and these are the markers that are usually present in AML. So if we look at ALL, the conventional B precursor ALL, it's characterized by the presence of CD10, CD19, CD79A, CD22, CD20 and TDT positivity, and not every patient has got positivity for all these markers, so it depends. Some of them may have some markers positive and some may be absent. The T cell form of leukemia, which is an aggressive form of ALL, presents with cytoplasmic CD3, surface CD3, CD2, CD5, CD7 positivity, whereas an AML blast is usually positive for MPO, CD13, CD33, CD64 and CD14 flow cytometry markers. And this further classifies AML blasts into different types, and a unique variant is M3 form of AML, where the treatment strategy and the treatment philosophy is very, very different from the other forms of AML. So we need to be very sure that we are not missing a M3 when we look at a patient with acute myeloid leukemia. They usually have lots and lots of our rods in their blast, which are called as promyelocytes. They can also be present in the M2 form of AML, so we need to distinguish that, and FISH markers and PCR helps us to differentiate between these two forms of AML. By flow cytometry, APML, which is the M3 variant, usually shows CD13, CD33 anti-MPO, and it usually has absence of HLA-DR and CD34 on their blasts. Monoblasts are characterized by CD14 and 64 positivity. Erythroblasts have got CD71 and glycophorin positivity, and megakaryoblast, which are the M7 variant of AML, have got CD41 and 61 positivity. A lot of advances have happened in the past few decades, and now we are looking at ALL from a genetic perspective, and a lot of chromosomal abnormalities that characterize AML have now been identified, and some of them have a favorable outcome and some of them are unfavorable and make the leukemia a high risk or a very high risk form of a leukemia. So if somebody has got a 1221, that is a TEL AML positivity, it's a favorable outcome. Hyperdiploidy carries a good outcome. Trisomy of certain chromosomes 4, 10, 17 has got a favorable outcome. Whereas if you have a translocation of 922, which is called as a Philadelphia chromosome positivity, it usually has an unfavorable outcome. But with new treatments and new targeted therapies, the outcome of this subset of leukemia has also greatly improved. But we actually need to identify this chromosomal translocation at the time of diagnosis, because that really means that for these patients we are able to give an extra drug which makes a huge impact on their overall outcome. And that is why doing all these chromosomal abnormality tests at the time of diagnosis is very important for prognostication and also for therapy modification, especially the 922 translocation. Hypodiploidy usually carries an unfavorable outcome, and we need to treat these leukemias very aggressively. Also, infants are a subset of the entire population of ALL who can have a relatively worse outcome as compared to the other children. They usually carry a MLL gene rearrangement, which is characterized by a 411, 911 or a 1119 translocation. It usually carries a unfavorable outcome. Their treatment strategy is different from the other ALLs, and this needs to be aggressively treated with a different protocol. I initially talked about risk stratification for ALL and also AML, and how that has actually modified the outcome of ALL and AML, and we are not over treating the standard risk ALL, and we are not under treating our high risk ALL, just because of these risk stratification that we have now identified over the last few decades. And still a lot of work, a lot of research is being done to improve this risk stratification and make the treatment suitable for that particular patient. So usually for ALL, the prognostic factors are divided as a favorable or an unfavorable prognostic factor. The favorable ones are usually an age of more than 1 year and less than 10 years. These usually come as a standard risk form of an ALL. A not very high white cell count. So if you have a high white cell count, like above 50 to 50,000 to say more than 1 lakh, they usually behave more aggressively and are treated on high risk protocols. A B precursor immunophenotype is generally a standard risk form of a ALL. I already told you about hyperdiploidy, translocation 1221, triple trisomies of different chromosomes, and one of the important tools that has now come and is actually being identified as the single best prognostic factor to predict overall outcome of a patient is something called as a MRD. So that is minimal residual disease. So we treat a patient for leukemia with chemotherapy, and then we assess the response. And if the response of the leukemia therapy is good, say after 1 month or say after 3 months of therapy, we have certain cutoffs for that. And if the patient's leukemic burden falls below a particular cutoff, we say that his response to leukemia is very good and he's likely to stay cured of his leukemia for a very, very long or for the rest of his life. So that is very important, and a lot of work is ongoing to improve this risk stratification further. We can have some adverse prognostic factors like translocation 922, MLL gene rearrangement, a high MRD, a child who is not in remission, that is the blast percentage after treatment for 1 month is not less than 5%, and all these factors where we actually call it as a high risk or a very high risk leukemia, and such children are not easily cured with the conventional chemotherapy. They may require a very, very aggressive form of chemotherapy or may require bone marrow transplant to cure their leukemia. Now, coming to the chromosomal abnormalities and genetic abnormalities in acute myeloid leukemia, this is a relatively difficult disease to treat as compared to ALL, and we do not have a lot of information about the risk stratification of acute myeloid leukemia, but again a lot of research is being done. But we definitely know that children with a 821 translocation or an inversion 16, so these are the abnormalities seen in the leukemic blasts. They usually carry a favorable outcome, and if somebody is positive for FLT3 mutation, they are usually high risk forms of AML, or the ones who present with a very high white cell count, or younger children with MLL gene rearrangement. They usually are aggressive forms of acute myeloid leukemia, and their treatment also needs to be tailored according to their risk and may require a bone marrow transplant to actually get a good outcome. So this particular form of AML, which is called acute promyelocytic leukemia, or M3 as I initially told, is a very unique form of APML. The crisis is usually within the first few weeks, and if we are able to pull out the patient from that initial crisis of first few weeks, the outcome of this particular form of AML is very, very good. They have a very severe coagulopathy at the time of presentation. We can see a high level of PT, APTT, a low fibrinogen, and a picture just like disseminated intravascular coagulation, or DIC, and we need to supplement these children with a lot of platelets, FFP, to take care of this DIC-like situation. Their blasts are characterized by this, lot of granular kind of a picture in their blast, along with the presence of hour rods, which are very characteristic of APML, and sometimes they are just seen in huge bunches of hour rods, and that actually tells the hematologist that we are probably dealing with APML. We quickly ask for, in such patients, we want to look for PCR positivity for 15-17 translocation. And if we identify that by FISH or RT-PCR, we know that the diagnosis is APML. But we usually, do not wait for all these reports to come. If we have a high clinical suspicion that the patient has APML, we actually start them on treatment. And the treatment is also very unique, because here we actually use differentiating agents like ATRA, where they convert these abnormal blasts into good cells. So it's actually, converting these blasts to behave properly and not cause all the trouble that they were actually causing when the child presents with acute leukemia. and also there is a role of chemotherapy. So we kind of mix these differentiating agents. The other important agent is arsenic, which is now being increasingly used to manage these patients. So arsenic form the differentiation therapy along with chemotherapy, and some centers actually use just differentiating agents to treat these children with APML. So as I told, we need to manage the DIC, and because of this arsenic, they can have something called as a differentiation syndrome, where when these blasts start converting into normal cells, the patient can present with breathing difficulty, weight gain, fluid accumulation, and we need to identify that early, because these two complications, DIC and differentiation syndrome, can have catastrophic outcome if not identified and managed appropriately. And if we are able to pull the patient through this phase, usually there is a very gratifying outcome of this particular form of leukemia. Just one slide about sanctuary sites. So this leukemia is notorious to go and hide in some places where actually, because of some natural barriers, chemotherapy is not able to go and penetrate and kill the leukemic blasts very well. One such site is CNS. So whenever a patient presents with leukemia, we do a lumbar puncture, get a few drops of CSF and look for the presence of blasts, and we give something called as an intrathecal chemotherapy, which kills these blasts in the CSF and also prevents leukemic infiltration into the CNS. Also, the other important sanctuary site is testis, and we need to be very careful. Even after finishing treatment, we need to follow up these patients, examine their testes, look for any CNS signs, because sometimes leukemia can relapse at these sanctuary sites because the penetration, as I said, of the chemotherapy agents is not very good. And we use radiotherapy to the brain if there is involvement of leukemia at the time of diagnosis. Just briefly, I'll touch upon the treatment of ALL. Usually it is 2 to 3 years of therapy. Boys are treated for a longer time than girls, because it was noticed that the chances of relapse of leukemia are more in boys, and with a longer duration, probably the chances of leukemic relapse are a little less. So the boys are usually treated in most protocols, not all protocols, for a longer duration of time. The treatment, which is essentially chemotherapy, and chemotherapy is basically drugs that kill cancer cells, are divided into a particular fashion based on the protocol that we are using. But essentially, most of the protocols give a 4-week induction chemotherapy. We do a marrow, we make sure that the bone marrow is in remission, and then this is followed by consolidation, high dose methotrexate or capiz based interim treatment, followed by a delayed intensification, and then a prolonged maintenance phase, which mainly is popping in some oral chemotherapy tablets for 1.5 to 2 years. So a very aggressive first initial 6 months, followed by oral therapy for 1.5 to 2 years, is essentially what the leukemia treatment looks like. Patients who come from far away for a leukemia therapy, we insist that they stay near the hospital for this initial period when the chances of infection, complications are much more, and once that 6-month period is over, they go back to their homes and come for checkup, say once or twice a month. Also, this treatment is accompanied by treatment which is directed against CNS, which mainly for pediatric ALLs includes intrathecal chemotherapy. So we do routine lumbar punctures along with this chemotherapy drugs that are mainly given IV or orally, and we inject chemotherapy into their CSF space, and that helps the leukemia control in the CNS. And bone marrow transplant also has a role in management of ALL, but it's mainly reserved for children who relapse after their initial treatment, or the ones who to begin with have a very high risk form of ALL, have very high MRD after the initial therapy, or a few of those who were initially refractory to the conventional treatment that was used. And in such cases, bone marrow transplant is done for these patients. Treatment of AML, so it's a more complicated treatment. It's a shorter treatment as compared to ALL, but a more difficult treatment to deliver because the TLC or the white cell count drops for very prolonged periods, and there is a prolonged hospitalization that is required. The treatment is usually for 4 to 5 months. Different protocols have 4 to 5 cycles of chemotherapy, and there is a bigger role of doing a bone marrow transplant in such patients, especially if they have high-risk features like FLT3 mutation, relapsed AML, refractory disease, and some forms of other difficult forms of AML that do not respond easily to the conventional chemotherapy. Very, very important is the role of nursing in the management of leukemias. They are the first contact for the patients. Their training includes handling of lines, handling of chemotherapy, and management of complications. And, things that nurses can do in management of leukemia, probably doctors cannot. And most of the time, they are on the bedside, giving that emotional and social support to the family, and also educating them all the time about hygiene and how to give medicines at home. So nurses play a huge role in managing children with leukemia. The other important aspects of supportive care are hand hygiene, cleanliness, daily bath, good nutrition, home-based food, and avoiding, street food while the treatment is going on. Aggressive management of infections is required. We always tell our families that, if your child has fever, don't sit at home. Bring the child immediately to the hospital, because this child is different from the other general population. They can have fever and can be managed with paracetamol at home, but these children, if they have a fever, they do not have a very good functioning, robust immune system, and then their infections can be life-threatening if there is a delay in treatment. So we insist on their coming to the hospital within 1.5 of spiking a fever, and aggressive antibiotic policies are in place in most of the centers who manage children with cancer. Also, to deliver the treatment, we use central lines because we do not want to prick these children every time they come to the hospital. It's a long treatment, lot of pricks, lot of pain. So, we try to put in central lines, and that makes their life good and easy. Sometimes we have to manage children without central lines, and a good cannulation team and expert pediatric faculty who can put these cannulas, we can manage leukemias in those cases. But these central lines require good care, and that is also a very essential thing whenever we manage children with leukemia. So I've already told you about the outcomes. In ALL, we are able to cure, say, 80 to 85% of children with ALL as a whole group. Some of the standard risk ALLs, the outcomes are actually above 90%, whereas in AML, we are able to cure, say, 50 to 60% of the children whom we treat for this particular malignancy. And chemotherapy alone is not enough. All these hi-fi diagnostic tests, all these things are at one side, but what is very important is a good supportive care, emotional support to the patient. They are going through a lot. We need to hold their hands and take them through this difficult journey with the help of NGOs, with the help of our social workers, with the help of our psychologists, and with the help of the patient and their family. We are able to get a good outcome if all of us work together to treat children with blood cancers. Thank you.